Assalamualaikum friends, welcome back to the channel. Today we're going to talk about one of the important genera of gram-positive cocci, and that is Staphylococcus. But before starting the lecture, I'd like to tell you guys that these videos are meant for educational purposes. Things and treatments may change with time. If I get wrong or miss anything, your input is always welcomed in the comments section. So, let's jump right into the video. Staphylococcus. It is a gram-positive cocci. It has got two words in it. First one is staphylo, which means cluster, and the second one is coccus, which means spherical. Spherical means kind of round, as you can see in this picture. And Staphylococcus resembles a bunch of grapes. As you can see, this one, it is actually resembling the bunch of grapes. It belongs to the family Staphylococcaceae and the order Bacillales. Staph bacteria are facultative anaerobes, so it means that can exist as aerobes, and anaerobes means in the presence of oxygen and in the absence of oxygen. They are non-motile because they don't have any motility apparatus or organ with them like a flagella. They are catalase positive. Catalase is an enzyme released by staph bacteria. We are going to talk about that in laboratory diagnosis, so wait for it. Lecture outline. As we're done with the introduction of Staphylococcus, now we'll be looking at its morphology, then classification, habitat, then its transmission and pathogenesis, then its clinical findings, lab diagnosis, treatment, prevention, and at the end, as usual, we'll review the lecture. Morphology. First, we'll talk about its shape. It is spherical, round, or berry-like in shape, as you can see, just like that. It is arranged in irregular grape-like clusters, and it might be in pairs or short chains. We're going to have a look at that. Its diameter varies from 0.5 to 1 micrometer, and it varies in color from white or yellow to blue or purple. It depends on the species of that bacteria. Structure. As I mentioned earlier, it has got no flagella, that's why it is non-motile. It has a capsule that is actually a polysaccharide capsule. It is an important virulence factor. There are 11 serotypes based on antigenicity of the capsular polysaccharide, but types 5 and 8 cause 85% of infections. Some strains of the Staph aureus, we're going to talk about that, are coated with a small amount of polysaccharide capsule called a microcapsule. The capsule is poorly immunogenic. That's why there's no effective vaccine against it, and it's difficult to make a vaccine. Now let's talk about the components and antigens of the cell wall. Number one in the list is protein A. A is the major protein in the cell wall and is an important virulence factor because it binds to the Fc portion of IgG at the complement binding site, thereby preventing the activation of complement. Next one in the list is teichoic acid. These are the polymers of ribitol phosphate, and they mediate adherence of the staphylococci to mucosal cells. And lipoteichoic acids play a role in the induction of septic shock induced by cytokines such as interleukin-1 and tumor necrotic factor alpha from macrophages. Third one in the list is surface receptor. There are surface receptors for specific staphylococcal bacteriophages that permit phage typing of strains. For epidemiologic purposes, teichoic acids make up part of these receptors. Last one in the list is the peptidoglycan. The peptidoglycan of Staph aureus has endotoxin-like properties, that is, can stimulate macrophages to produce cytokines and can activate the complement and coagulation cascades. This bacteria do have a cell membrane. I've got a detailed video on bacterial structure. It is linked in the description or in the top right corner. Watch that one, then you'll have a great grip on the bacterial structure. As you can see in this picture, these are certain toxins released by different types of these staph bacteria. We're going to talk about them. And the toxin, the first toxin is toxic shock syndrome, toxin type 1, then staphylococcal enterotoxins, and alpha toxin. This is the capsule, this is peptidoglycan layer, this is its membrane, and certain enzymes like coagulase, catalase, and certain proteins are released. And these are lipoteichoic acids. If we zoom this section, we'll get to know that there are certain things incorporated into that area. Number one is lipoteichoic acid, then clumping factors, then fibronectin binding proteins, collagen adhesins, and lipoproteins. Classification of Staphylococcus. Staphylococcus is classified into 3 species, and these are important human pathogens. Number one is Staphylococcus aureus, that is the most common and responsible for causing most serious infections. The second one is Staphylococcus epidermidis, and the third one is Staphylococcus saprophyticus. Beings are the main reservoirs for Staphylococcus aureus and epidermidis, as they are a part of the human normal skin flora. They may be present at nares or nasal area. For saprophyticus, it is present in perineum, that is the region between the anus and the urogenital tract. So the distance between the anus and urogenital tract of females is quite small, so this organism is responsible for causing infection mainly in females and is also present in urogenital tract of females. Let me tell you something really cool about Staphylococcus saprophyticus. It thrives or may survive in decaying organic material, especially like meats. Imagine you ate a steak and it has potential decaying type of organic material, and Staph saprophyticus survives in that. After eating that, you digest it, and then some of its contents are released in feces. Within that fecal matter at rectum area is the Staph saprophyticus. It loves to colonize in that area, and this area is called perineum. As I told you, is the space between the rectum and the genitals. The urogenital tract of females is in very close proximity to anus and to the perineal region, so this bacteria can easily spread to urogenital tract and colonize those areas as well. Transmission occurs by hand contact, fomites, venipuncture, and devices like catheters, like a urinary catheter, or prosthetic devices like prosthetic heart valves, or prosthetic joints like hip joint, and tampons which are left in for a long time, or nasal packings, maybe surgery lap pad. After surgery, Staphylococcus get into the skin and is responsible for causing infection. Pathogenesis. Let's talk about Staphylococcus aureus first. It is responsible for causing infections in human beings by 2 main mechanisms. Number 1, by releasing biofilms. Number 2, by producing exotoxins. It releases biofilms maybe due to a presence of a catheter or any other device like a prosthetic device, and these biofilms protect the bacteria against the immune system and antibiotics, because it evades the immune system and antibiotics and does not allow these two to kill the bacteria. And it also produces exotoxins like toxic shock syndrome toxin type 1, maybe enterotoxin, exfoliative toxin that damage host tissues and cause inflammation and many infections, and it invades host cells to establish persistent infections and causes a wide range of infections including skin and soft tissue infections, pneumonia, bloodstream infections, and toxic shock syndrome. Pathogenesis of Staphylococcus epidermidis. It adheres to medical devices such as catheters and implants, and it then forms biofilms on those device surfaces and evade the immune system and antibiotics. Then it causes device-related infections like catheter-associated urinary tract infections and infections that are associated with implanted medical devices like prosthetic hip joints or prosthetic heart valves. Pathogenesis of Staphylococcus saprophyticus. It adheres to urinary tract epithelium and colonizes the bladder. It has these specialized adhesive structures to stick to urinary tract valves. It also causes infection when a catheter is present for a long time. It causes urinary tract infections and is most common in females. Symptoms like urinary frequency, dysuria, and occasionally fever can occur. Clinical findings. Staphylococcus aureus is responsible for causing many infections. Out of them, skin and soft tissue infections are really important. It is responsible for causing furuncle. Prior to explaining them, let me tell you that there are 3 layers of the skin. First one is epidermis, and we've got dermis and then hypodermis. If this infection is limited to epidermis and is causing boils in epidermis, then this is called furuncle, and combination of furuncles is called carbuncle. And if the infection involves dermis along with epidermis, then it is responsible for causing impetigo and cellulitis. And if the infection spreads down to other layers of the skin, it is responsible for causing skin abscesses. Muscle, bone, and joint infections. If the inflammation or infection occurs in muscle, it is called pyomyositis, and if same occurs for bone, it is osteomyelitis, and if the infection or the inflammation occurs in joint, it is called septic arthritis. Bloodstream infection. If the bacteria spreads to the blood, and there are three main ways that it can, like a hematogenous spread, maybe due to surgery, maybe due to IV drug abuses. So presence of bacteria in blood is termed as bacteremia. As we know that blood goes all around the body, when it spreads to the brain, it causes meningitis and brain abscess, and when it goes towards the lungs, it's responsible for causing pneumonia. When it through the blood reaches the heart, it can cause infective endocarditis. As I've mentioned earlier, that Staph aureus also releases certain exotoxins, so these are called toxin mediated syndromes. The enterotoxin responsible for causing food poisoning, and secondary to that is gastroenteritis. The toxic shock syndrome, toxin type 1, is responsible for causing toxic shock syndrome, and the exfoliative toxin can cause Staphylococcus scalded skin syndrome. Staphylococcus epidermidis has got following findings: catheter-associated infections, catheter-associated urinary tract infections, abbreviated as CAUTI, C-A-U-T-I, and it can also cause prostatic valve infections and prostatic joint infections, mainly the hip joint. Staphylococcus saprophyticus, it is responsible for causing urinary tract infections, mainly cystitis. It is really common, but pyelonephritis can also occur. Lab diagnosis. For diagnosing this bacteria, we'll need samples. We'll need sample of skin, soft tissues. We'll need sample of blood, sputum, bronchoalveolar lavage fluid, BAL fluid. Tracheal aspirates, urine, and catheters of prostatic devices, because the organism may be present on these devices, so we will definitely need them. Microscopy. Gram-positive cocci will be seen with the gram stain. Smear under the microscope will reveal crab-like cluster that might be in pairs or short chains, blue or purple color due to crystal violet stain. As you can see, this picture, it is the staph under microscope. It is usually blue or purple in color, but as this is a drawing, so it might be yellow at the moment. As you can see, it has got these short chains, this bunch, and it's round in shape, and it also has got some pairs just like that one. Catalase test. This is an enzyme released by all the staph bacteria, so this is going to be positive for all the three staph. It is confirmed by the bubbles formation. Let me tell you how this test happens. For example, we take a petri dish and put a solution containing hydrogen peroxide in it, and then we put that bacteria in that solution. If this bacteria releases catalase, this will convert hydrogen peroxide into water plus oxygen. Oxygen is responsible for causing bubbles, so bubbles will be formed and will confirm that it is a catalase positive bacteria. If it does not convert hydrogen peroxide into water and oxygen and no bubbles are formed, then this is a catalase negative bacteria. As you know, Staph are catalase positive bacteria, so it will form bubbles in the petri dish. So as you can see on this slide and in this tube, and the one having no bubbles is catalase negative. There are three staph bacteria, and all are responsible for causing different diseases. So how we are going to differentiate them? Here, coagulase test comes into play. It is confirmed by clumping. It is positive for Staph aureus but negative for Staph epidermidis and Staph saprophyticus. Coagulase is an enzyme that causes plasma to clot by activating prothrombin to form thrombin. Thrombin then catalyzes the activation of fibrinogen to form the fibrin clot. Staph epidermidis and Staph saprophyticus are often referred to as coagulase negative staphylococci, but Staph aureus is coagulase positive staphylococci. As you can see here, fibrinogen is converted in the presence of coagulase into fibrin, and it is forming clumps. So which bacteria will clump up? Staph aureus. Same goes for this diagram. Clots formed, and this is coagulase positive. That is Staph aureus, and no clots are formed. This is coagulase negative, and Staph saprophyticus and epidermidis fall into that category. Culture. You are going to look at two cultures, one solid medium, the solid culture, and the other one, the liquid culture, the liquid medium. In solid medium, normally we use the mannitol salt agar. Colonies appear, and these colonies are round, smooth to slightly rough or wrinkled, raised, golden yellow, but depends on the type of bacteria, it is opaque with distinct margin. For coagulase positive staph, yellow colonies will appear, but for coagulase negative staph, white colonies will appear, as you can see in this picture. Let me explain it to you. Cultures of Staph aureus typically yield golden yellow colonies that are usually beta hemolytic. Staph aureus is a coagulase positive. The mannitol salt agar is a commonly used screening device for Staph aureus. Do you know why Staph aureus produces golden yellow colonies? Because Staph aureus ferments mannitol, which lowers the pH, causing the agar to turn yellow, whereas Staph epidermidis does not ferment mannitol and the agar remains pink, white. As you can see, it is pink, white, and also yellow. So you might be now able to tell me which one is which bacteria. Now let's talk about the liquid medium. For liquid medium, we use urea broth with phenol red, but in this picture, it's just urea broth. No phenol red is added right now. After the completion of the process, I'm going to tell you process in a moment, small clumps or aggregates are formed. Then it appears turbid or cloudy, and clumps will settle down at the bottom of the culture tube or may float. This liquid medium urea broth test is positive for Staph epidermidis and Staph saprophyticus. You know what's the specific name for this test? This is urease test. So bacteria who are going to give this test positive will be urease positive, and the ones who will give this negative will be urease negative bacteria. Process of the urease test. This is the result that is forming the clumps, maybe floating at the top of the culture tube or maybe settling down at the bottom. If phenol red is added into the urea broth, it will turn red like that. When the bacteria is added and this bacteria has got no urease enzyme in it, so it will turn back to its original color, and this is termed as urease negative bacteria. And when a bacteria added to this urea broth with phenol red and it has the urease enzyme in it, it will convert urea into ammonia and will turn this red color into pink and will form clumps maybe at the bottom of the culture tube or maybe floating in the top of the culture tube. Now we know that we can differentiate Staph aureus and Staph epidermidis and saprophyticus by coagulase test, because Staph aureus is coagulase positive while the other two are coagulase negative. Now, how do we differentiate Staph epidermidis and saprophyticus? Novobiocin sensitivity test can help us there. This is actually putting bacteria in novobiocin, and we are going to know that is this bacteria resistant or bacteria sensitive to the novobiocin. So if a bacteria die, it will be novobiocin sensitive, and if bacteria don't die, they survive, they are novobiocin resistant. Let's suppose we have got a petri dish having a novobiocin antibiotic disc in the center and the other part of the petri dish is covered with the bacteria. If this bacteria survive in that situation, this is resistant to novobiocin. And look who is resistant to novobiocin. It's Staph saprophyticus. And if the bacteria do not survive in the presence of novobiocin antibiotic disc, it means it is sensitive to novobiocin. Look who's sensitive. It's Staph epidermidis. There are no serologic tests done for these bacteria, but maybe sometimes done like agglutination test. There are no skin tests, and for toxic shock syndrome, signs and symptoms are pretty much enough for the diagnosis. Treatment depends on the type of bacteria and its resistance or its sensitivity to certain types of antibiotics. For Staph aureus, the antibiotics are classified into methicillin sensitive Staph aureus, MESA, and which include oxacillin and nafcillin. The other one is methicillin resistant Staph aureus, which is MRSA, that include doxycycline, vancomycin, clindamycin, trimethoprim sulfamethoxazole. And the third one is vancomycin resistant Staph aureus, WRSA. It is linezolid. For Staphylococcus epidermidis, antibiotics are classified into methicillin sensitive Staph epidermidis, which includes oxacillin and nafcillin, and the other one is methicillin resistant Staph epidermidis, which includes vancomycin. For Staphylococcus saprophyticus, antibiotics are classified into first and second line antibiotics. First line antibiotics include nitrofurantoin, trimethoprim sulfamethoxazole, and fosfomycin. The second line antibiotics include cephalexin, augmentin, and ciprofloxacin. The treatment of toxic shock syndrome involves correction of shock by using fluids, suppressor drugs, and inotropic drugs, administration of a beta-lactamase resistant penicillin such as nafcillin, and also pooled serum globulins can be used, which contain antibodies against toxic shock syndrome type 1 toxin. Mupirocin is very effective as topical antibiotic in skin infections caused by Staph aureus. It has also been used to reduce nasal carriage of organisms in hospital staff and patients with recurrent staphylococcal infections. A topical skin antiseptic such as chlorhexidine can be added to mupirocin. There are also certain procedures that can help eliminate the disease. First one in the list is drainage, that can be spontaneous or surgical and is the cornerstone of the abscess treatment. Second one is incision and drainage and is often sufficient treatment for skin abscesses and furuncles, the boils. For Staph epidermidis and saprophyticus, removal of catheter, maybe urinary catheters, or removal of tampons, removal of nasal pack-ins, or surgical lap pads can be effective, and also debridement of infected site. And there are no vaccines that work against staphylococcal infections because its membrane is poorly immunogenic. Prevention. As we know that there's no vaccine that can work against staphylococci, so cleanliness, frequent hand washing, and aseptic management of lesions can help to control the spread of Staph aureus. Persistent colonization of nose by Staph aureus can be reduced by intranasal mupirocin or by oral antibiotics such as trimethoprim sulfamethoxazole. Shatters may have to be removed, and cefazolin is often used preoperatively to prevent staphylococcal surgical wound infections. Let's review everything really quick. The organism is Staphylococcus, which is responsible for causing diseases like toxic shock syndrome, UTIs, food poisoning, and secondary to that is gastroenteritis, some skin, muscle, bone, and joint infections, organ infections like pneumonia, endocarditis, meningitis, and devices associated infections like catheters and prostatic implants associated infections. Transmission occurs by hand contact, fomites, venipuncture, devices, and surgery. Hosts are the human beings. Primary locations are skin and genital tract. Diagnosis is made by microscopy by seeing gram-positive cocci in pairs or short chains and is catalase positive, coagulase positive and negative, and urease positive and negative, and also novobisin sensitive or resistant. Treatment is done by giving antibiotics like oxacillin, vancomycin, linezolid, nitrofurantoin, trimethoprim sulfamethoxazole, and cephalexin. And there are some procedures like incision and drainage and removal of devices. That's it for today's video. I hope you guys enjoyed it. You've learned something. If you really did, give this video a big thumbs up. Comment down below in the comment section. And also, if you think this is important, you can share it with your friends. If you want to connect with me on my socials, I've got my Instagram where I upload amazing infographics for you guys, like resources for pathology. I do have a Twitter and I rarely upload blogs, so if you spare some time to give it a visit. Till then, Assalamualaikum.